Orthotics, 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 orthotics. Orthotics Greek, orthos, romanized, ortho, lit, to straighten, to align is a medical specialty that focuses on the design and application of orthoses. An orthosis plural orthoses is an externally applied device used to influence the structural and functional characteristics of the neuromuscular and skeletal system. Classification. Orthoses, orthotic devices, are classified into classes of 4 body areas according to the International Classification System ICS. There are the orthotics of the lower extremities English, classes of lower limb orthoses, orthotics of the upper extremities English, classes of upper limb orthoses, orthoses for the trunk English, classes of spinal orthoses and orthotics for the head English, classes of head orthoses. In the area of the respective classes, orthoses, orthotic devices are grouped according to their function. There are paralysis orthoses, relief orthoses, and soft braces. Under the international standard terminology, orthoses are classified by an acronym describing the anatomical joints which they contain. For example, a knee-ankle-foot orthosis English abbreviation, COFO for knee-ankle-foot orthosis spans the knee joint, the ankle, and the foot. A spinal orthosis English abbreviation, TLSO for thoracolumbo-sacral orthosis affects the thoracic spine, the lumbar spine, and the sacrum. Use of the international standard is promoted to reduce the widespread variation in description of orthoses, which is often a barrier to interpretation of research studies. The transition from an orthosis to a prosthesis can be fluid. An example of this is compensating for a leg length discrepancy, which is equivalent to replacing a missing part of a limb. Another example is the replacement of the forefoot after a forefoot amputation. This treatment is often made from a combination of a prosthesis to replace the forefoot and an orthosis to replace the lost muscular function orthoprosthesis. Prescription and manufacturing. Lower limb orthoses. All orthoses that affect the foot, the ankle joint, the lower leg, the knee joint, the thigh or the hip joint belong to the category of orthoses for the lower extremities. Paralysis orthoses. Determination of strength levels for physical examination. In the case of paralysis due to diseases or injuries to the spinal/peripheral nervous system, the strength levels of the 6 major muscle groups of the affected leg are first determined as part of the physical examination, in order to determine the necessary functions of an orthosis. The dorsiflexors move the foot through concentric muscle work around the axis of the ankle in the direction of dorsiflexion and control the plantar flexion through eccentric muscle work. The plantar flexors contribute significantly to being able to stand upright by actuating the forefoot lever and thereby increasing the standing area when standing. This group of muscles moves the foot in the direction of plantar flexion. The knee extensors extend the knee in the direction of the knee extension. The knee flexors bend the knee in the direction of the knee flexion. The hip flexors bend the hip joint in the direction of the hip flexion. The hip extensors stretch the hip joint in the direction of the hip extension, and at the same time extend the knee in the direction of the knee extension. A muscle function test according to Vladimir Janda is carried out to determine the strength levels. The degree of paralysis is given for each muscle group on a scale from 0 to 5, with the value 0 indicating complete paralysis 0% and the value 5 indicating normal strength 100%. The values between 0 and 5 indicate a percentage reduction in muscle function. All strength levels below 5 are referred as muscle weakness. The combination of strength levels of the muscle groups determines the type of orthosis AFO or COFO. In addition, the strength levels of the muscle groups result in the necessary functional elements of the orthosis, which compensate for the restrictions caused by the reduced level of strength of the respective muscular functions. Physical examination for paralysis due to diseases or injuries to the spinal cord/peripheral nervous system. Paralysis may be caused by diseases or injuries to the spinal or peripheral nervous system after spinal cord injury and also occur in spina bifida, poliomyelitis, and Charcot-Marie tooth disease. In this group of paralyses, the inclusion of the strength levels of the large muscle groups is of elementary importance in order to determine the necessary orthotic functions when configuring the orthosis. Physical examination for paralysis due to diseases or injuries to the central nervous system. Paralysis caused by diseases or injuries to the central nervous system, e.g., cerebral palsy, traumatic brain injury, stroke, and multiple sclerosis. When determining the necessary functions of an orthosis, it makes sense to consider the group of paralyses caused by diseases or injuries to the central nervous system separately from the group of paralyses due to diseases or injuries to the spinal or peripheral nervous system. Incorrect motor impulses from the central nervous system often result in clearly visible deviations in the gait pattern. The necessary functions of an orthosis in this group of paralyses can therefore only be determined to a limited extent by determining the muscle weakness and strength levels of the 6 major muscle groups. Even with results with high degrees of strength, disturbances of the gait pattern can be recognizable in these paralyses due to the incorrect control of the central nervous system. Cerebral palsy (CP) and traumatic brain injury. In patients with paralysis due to cerebral palsy (CP) and traumatic brain injury, but who are able to walk, the gait pattern is analyzed as part of the physical examination to determine the necessary functions of an orthosis. One way of assessing is the classification according to the Amsterdam Gait Classification. According to this classification method, 5 gait types are described. To assess the gait pattern, the patient is viewed visually or via video recording from the side of the leg to be assessed. At the point in time at which the leg to be viewed is in mid-stance and the leg not to be viewed in mid-swing, the knee angle and also the contact of the foot with the ground are assessed. In gait type 1, the knee angle is normal and foot contact is complete. In gait type 2, the knee angle is hyperextended and the foot contact is complete. In gait type 3, the knee angle is hyperextended and foot contact is incomplete only on the forefoot. In gait type 4, the knee angle is flexed and foot contact is incomplete only on the forefoot. At gait 5, the knee angle is flexed and foot contact is complete. Gait type 5 is also known as crouch gait. Patients with paralysis due to cerebral palsy or traumatic brain injury are usually treated with an ankle-foot orthosis AFO. The functional elements to be used in the orthosis are the same as the functional elements of an AFO to compensate for paralysis of large muscle groups. However, it is important to understand that the muscle groups are not paralyzed, but are controlled by the brain with the wrong impulses. The compensatory gait is an unconscious reaction to the lack of security when standing or walking. The gait pattern usually worsens with increasing age. If the right functional elements are integrated into the orthosis, which both maintain physiological mobility and provide security when standing and walking, the necessary motor impulses can be created to create new cerebral connections. The goal of an orthotic fitting is the best possible approximation of the physiological gait pattern. Stroke. In the case of paralysis after a stroke, often areas of the brain are affected that contain programs for controlling the musculoskeletal system. With the help of an orthosis, physiological standing and walking can be learned again, and late health consequences caused by a wrong gait pattern can be prevented. In order to consider the correct functional elements when configuring the orthosis, it is important to understand an important basic requirement for regaining the ability to walk is that the patient trains early on to be able to stand on both legs safely and well balanced. An orthosis with functional elements to support balance and safety when standing and walking can already be integrated into the therapy concept. This makes the work of mobilizing the patient at an early stage easier. If the right functional elements are integrated into the orthosis, which both maintain physiological mobility and provide security when standing and walking, the necessary motor impulses can be created to create new cerebral connections. Clinical studies confirm the importance of orthoses in stroke rehabilitation. Patients with paralysis after a stroke are often treated with an ankle-foot orthosis AFO. After a stroke, it can happen that only the dorsiflexors are supplied with incorrect impulses from the central nervous system, which can lead to the risk of stumbling due to insufficient foot lifting when walking during swing phase. In these cases, an orthosis that only has functional elements to support the dorsiflexors can be helpful. Such an orthosis is also called drop foot orthosis. However, when configuring such a foot lifter orthosis, it makes sense to use adjustable functional elements for setting the resistance, which make it possible to adapt the passive lowering of the forefoot plantar flexion to the eccentric work of the dorsal flexors during loading response. In many cases, the muscle group of the plantar flexors is supplied with wrong impulses from the central nervous system, which leads to great uncertainty when standing and walking. The compensatory gait is an unconscious reaction to the lack of security when standing or walking. When configuring an orthosis, functional elements that can restore safety when standing and walking must be used in these cases. In such cases, a foot lifter orthosis is not suitable for restoring the lack of safety, since it only has functional elements that compensate for the functional deviations in the event of weakness of the dorsiflexors. In patients with paralysis after stroke, but who are able to walk, have the option of analyzing the gait pattern as part of the patient history in order to determine the optimal function of an orthosis. One way of assessing is the classification according to the NAP gait classification. NAP is a physiotherapeutic treatment concept. According to this classification, 4 gait types are described. The gait pattern is assessed in the gait phase, in which the leg to be viewed is in mid-stance phase and the leg not to be viewed is in mid-swing. To assess the gait in the first step, the patient is viewed visually or via video recording from the side of the leg to be assessed. In gait type 1, the knee angle is hyperextended. In gait type 2, the knee angle is flexed. The patient is then viewed from the front. If the forefoot is on the outer edge of the foot, which is accompanied by a varus position in the knee, the letter A is added to the gait. This foot position is called inversion. If the patient stands on the inner edge of the foot, which is associated with a valgus position in the knee, the letter B is added to the gait type. This foot position is called eversion. The patient can be classified according to gait types 1A, 1, 2, or tube. The goal of orthotic fitting for patients who are able to walk is the best possible approximation of the physiological gait pattern. Multiple sclerosis MS. In the case of paralysis due to multiple sclerosis, the degree of strength of the 6 major muscle groups of the affected leg should be determined as part of the physical examination, just as in the case of diseases or injuries to the spinal/peripheral nervous system, in order to determine the necessary functions of an orthosis. However, patients with multiple sclerosis may experience muscular or cognitive fatigue beyond the physiological level. The fatigue can be more or less pronounced and, depending on the severity, lead to considerable restrictions in everyday life. Persistent stress, e.g., walking, causes a deterioration in muscle function and has a significant effect on the spatial and temporal parameters when walking, for example, by significantly reducing the cadence and walking speed. Fatigue can be measured as muscle weakness. As part of the patient's medical history when determining the strength levels of the 6 major muscle groups, fatigue can be taken into account by using a standardized walking test. The 6-minute walk test is suitable for this. The muscle function test, according to Vladimir Janda, is carried out in combination with the 6-minute walk test in the following steps. First, muscle function test without muscular fatigue. 6-minute walk test directly followed by a load by, 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 Second, muscle function test with muscular fatigue. This sequence of muscle function test and minute walk test is used to check whether a controlled muscular fatigue can be induced. If the test reveals that there is muscular fatigue, the strength levels should be included in the planning of an orthosis, taking into account the measured fatigue when determining the functional elements. Functional deviations in the case of paralysis of large muscle groups. Paralysis of the dorsiflexors. Weakness of the dorsiflexors results in a so-called drop foot. The patient's foot can only be insufficiently lifted when walking during the swing phase, since the necessary concentric work of the dorsiflexors cannot be activated. There is a risk of stumbling. In addition, the patient cannot influence the shock absorption when walking gait phase, loading response, as the eccentric work of the dorsiflexors is limited. After initial heel contact, the forefoot slaps too quickly on the floor via the heel rocker, which creates an audible noise, or the foot does touch the floor with forefoot first, which disrupts gait development. 178, 181, 44, 45, 50, 54, and 126. Paralysis of the plantar flexors. If the plantar flexors are weak, the muscles of the forefoot lever are only inadequately activated or not activated at all. The patient has no balance when standing and has to support himself with aids such as crutches. There is a loss of energy during walking. The forefoot lever required for energy-saving walking in the gait phases from mid-stance to pre-swing cannot be activated by the plantar flexors. This leads to excessive dorsiflexion in the ankle joint in terminal stance. The center of gravity of the body lowers towards the end of the stance phase, and the knee of the contralateral leg is flexed excessively. With each step, the center of gravity must be raised above the leg with the excessively flexed knee by straightening it. Since the plantar flexors have their origin above the knee joint, they also have a knee extension effect in the stance phase. 177, 210, 72. Paralysis of the knee extensors. If the knee extensors are weak, there is an increased risk of falling. The physiological knee flexion is only inadequately or not controlled by the knee extensors when walking between loading response to the mid-stance. To control the knee, the patient develops compensatory mechanisms that lead to an incorrect gait pattern. That leads, for example, in the initial contact with the forefoot and not with the heel takes place in order to prevent the knee flexing effect of the heel rocker. Another way to compensate for weak knee extensors is to exaggerate the activation of the plantar flexors, which leads into hyperextension of the knee. 222, 226, 132, 143, 148, 149. Paralysis of the knee flexors. If the knee flexors are weak, it is more difficult to flex the knee in pre-swing. 220, 154. Paralysis of the hip flexors. If the hip flexors are weak, it is more difficult to flex the knee in pre-swing. 221, 154. Paralysis of the hip extensors. The hip extensors support the control of the knee against unwanted flexion when walking between loading response and mid-stance. 216, 17, 45, 46. Functional elements for correction of functional deviations in large muscle groups. The functional elements of an orthosis ensure the flexion and extension movements of the ankle joint, the knee joint, and the hip joint. They correct and control the movements and secure the joints against undesired incorrect movements, e.g., to avoid falls when standing or walking. Functional elements in paralysis of the dorsiflexors. If the dorsiflexors are weak, an orthosis should lift the forefoot during the swing phase in order to reduce the risk of the patient stumbling. An orthosis that has only one functional element for lifting the forefoot in order to compensate for a weakness in the dorsiflexors is also known as a drop foot orthosis. If other muscle groups, such as the plantar flexors, are weak, additional functional elements must be taken into account. An AFO of the drop foot orthosis type is therefore not suitable for the care of patients with weakness in other muscle groups. In addition, initial contact with the heel should be achieved by lifting the foot through the orthosis. If the dorsiflexors are very weak, dynamic functional elements in which the resistance of the plantar flexion can be adjusted should also take over the control of the rapid drop of the forefoot. They should be able to be adapted to the functional deviation of the dorsiflexors in order to correct the shock absorption via the heel rocker lever of the orthosis in loading response without blocking the plantar flexion. Static functional elements that block the plantar flexion of the ankle joint lead to excessive flexion in knee and hip, and thereby to an increased energy consumption when walking. 105. 134 functional elements in paralysis of the plantar flexors. In order to compensate for a weakness of the plantar flexors, the orthosis has to transfer great forces that the strong muscle group of the plantar flexors would otherwise take over. The forces in the orthosis are transmitted in a similar way to a ski boot during downhill skiing via the functional elements of the foot part, ankle joint, and lower leg shell. Dynamic functional elements should preferably be used in the ankle joint in order to secure the dorsiflexion. Static functional elements would completely block the dorsiflexion. A completely blocked dorsiflexion would have to be compensated by compensatory movements in the upper body, which would result in an increasing of energy cost when walking. The resistance of the functional element to protect against unwanted dorsiflexion should be able to be adapted to the weakness of the plantar flexors. In the case of very weak plantar flexors, the resistance of the functional element to secure against undesired dorsiflexion must be very high in order to be able to compensate for the functional deviations of the plantar flexors. Adjustable functional elements of an orthosis allow an exact adjustment of the resistance to the weakness of the muscle, and scientific studies have come to the recommendation that the resistance of the orthosis should be adjustable in fascia. Functional elements in paralysis of knee extensors and hip extensors. In the case of weak knee extensors or hip extensors, the orthosis must take over the stability and stance phase control when walking. Depending on the weakness of these two muscle groups, different knee-securing functional elements are integrated into the orthosis. In order to compensate for functional deviations with slightly weakness of these muscle groups, free-moving mechanical knee joints with a posterior shift of the mechanical pivot point behind the anatomical knee pivot point can be sufficient. In the case of significant weakness, the knee flexion effect when walking must be controlled by functional elements that mechanically secure the knee joint against unwanted knee flexion in the early stance phases between loading response and mid-stance. Stance phase control knee joints can be used here. These lock the knee joint in the early stance phases and release the knee joint for knee flexion during the swing phase. With stance phase control knee joints, a natural gait pattern can be achieved despite mechanical securing against unwanted knee flexion. In these cases, locked knee joints are often used, which have a good safety function, but do not allow knee flexion when walking during swing phase. The knee joint remains mechanically locked during the swing phase. Patients with locked knee joints have to manage the swing phase with stiff leg. This only works if the patient develops compensatory mechanisms, e.g. by raising the body's center of gravity in the swing phase Dutch and limping, or by swinging the orthotic leg to the side circumduction. Stance phase control knee joints and locked joints can be mechanically unlocked so that the knee joint can be flexed to sit down. Ankle-foot orthosis AFO in the field of paralysis orthoses. Knee ankle-foot orthosis COFO in the field of paralysis orthoses. COFO is the abbreviation for ankle-foot orthoses, English name for an orthosis that spans the knee, the ankle, and the foot. In the treatment of paralyzed patients, a COFO is used when there is a weakness of the knee extensors or hip extensors. The orthotic ankle joint forms the connection between the foot shell and the lower leg shell, and the orthotic knee joint forms the connection between the lower leg shell and the thigh shell. Different functional elements to compensate for a weakness of the dorsiflexors or a weakness of the plantar flexors can be integrated into the ankle joint of the orthosis depending on the combination of the degree of paralysis. It is of great advantage if the resistances for these two functional elements can be set separately. The functional elements to compensate for paralysis of the knee-securing muscle groups, the knee extensors and the hip extensors, are integrated into the knee joint of the orthosis via knee-securing functional elements. A COFO can compensate for the limitations of the named muscle groups through the variety of combinations of different variants in the stiffness of the foot shell, the different variants of the functional elements of a dynamic ankle joint, the variants in the shape of the lower leg shell, and the functional elements of a knee joint. Hip knee ankle foot orthosis HCOFO in the field of paralysis orthoses. HCOFO is the abbreviation for ankle-foot orthoses, English name for an orthosis that spans the hip, the knee, the ankle, and the foot. In the treatment of paralyzed patients, a HCOFO is used when there is a weakness of the pelvic stabilizing trunk muscles. Relief orthoses. Relief orthoses are used both in degeneration and after injuries to joints. These includes torn ligaments and wear and tear of joints. Relief orthoses are also used after operations such as a complete replacement of a joint or operations on the joint structure, or other operations on bony, muscular structures or operations on the joint ligaments. Relief orthosis may also be used to, used to, who, used to, used to, used to, used to. Control, guide, limit, and slash or immobilize an extremity, joint, or body segment for a particular reason, restrict movement in a given direction, assist movement generally, reduce weight-bearing forces for a particular purpose, aid rehabilitation from fractures after the removal of a cast, otherwise correct the shape and slash or function of the body to provide easier movement capability or reduce pain. Ulcer healing orthosis UHO. A custom-made ankle/foot orthosis for the treatment of patients having plantar ulcers is disclosed, which comprises a rigid L-shaped support member and a rigid anterior support shell hingedly articulated to the L-shaped support member. The plantar portion of the L-shaped member further comprises at least one ulcer protecting hollow spatially located for fitted placement in inferior adjacency to a user's plantar ulcer, thus allowing the user to transfer the user's weight away from the plantar ulcer and facilitating plantar ulcer treatment. The anterior support shell is designed for lateral hinged attachment to the L-shaped member to take advantage of medial tibial flare structure for enhancing the weight-bearing properties of the disclosed orthosis. A flexible, polyethylene hinge member hingely attaches the anterior support shell to the L-shaped member, and securing straps securely attach the anterior support shell in fixed, weight-bearing relation about the proximal, anterior portion of the user's lower leg. Foot orthoses FO. Foot orthoses, commonly called orthotics, are devices inserted into shoes to provide support for the foot by redistributing ground reaction forces acting on the foot joints while standing, walking, or running. They may be either pre-molded, also called prefabricated, or custom-made according to a cast or impression of the foot. A great body of information exists within the orthotic literature describing their medical use for people with foot problems, as well as the impact orthotics can have on foot, knee, hip, and spine deformities. They are used by everyone from athletes to the elderly to accommodate biomechanical deformities and a variety of soft tissue conditions. Foot orthoses are effective at reducing pain for people with painful high-arched feet, and may be effective for people with rheumatoid arthritis, plantar fasciitis, first metatarsophalangeal MTP joint pain, or hallux valgus bunions. For children with juvenile idiopathic arthritis, JAA custom-made and prefabricated foot orthoses may also reduce foot pain. Foot orthoses may also be used in conjunction with properly fitted orthopedic footwear in the prevention of foot ulcers in the at-risk diabetic foot. A real-time weight-bearing orthotic can be created using a neutral position casting device and the vertical foot alignment system VFAS. Ankle-foot orthosis AFO. In the field of relief orthoses, an AFO is also used to immobilize the ankle and lower leg in the presence of arthritis or fracture. Ankle-foot orthoses are the most commonly used orthoses, making up about 26% of all orthoses provided in the United States. According to a review of Medicare payment data from 2001 to 2006, the base cost of an AFO was about $500 to $700. Knee orthosis KO. In the field of relief orthoses, a knee orthosis KO or knee brace is a brace that extends above and below the knee joint and is generally worn to support or align the knee. In the case of diseases causing neurological or muscular impairment of muscles surrounding the knee, A KO can prevent flexion or extension instability of the knee. In the case of conditions affecting the ligaments or cartilage of the knee, a KO can provide stabilization to the knee by replacing the function of these injured or damaged parts. For instance, knee braces can be used to relieve pressure from the part of the knee joint affected by diseases such as arthritis or osteoarthritis by realigning the knee joint into valgus or varus. In this way, a KO may help reduce osteoarthritis pain. However, there is no clear evidence to advise people with osteoarthritis of the knee about the most effective orthosis to use or the best approach to rehabilitation. A knee brace is not meant to treat an injury or disease on its own, but is used as a component of treatment along with drugs, physical therapy, and possibly surgery. When used properly, a knee brace may help an individual to stay active by enhancing the position and movement of the knee or reducing pain. Prophylactic, functional, and rehabilitation braces. Prophylactic braces are used primarily by athletes participating in contact sports. Evidence about prophylactic knee braces. The ones football linemen wear that are often rigid with a knee hinge indicates they are ineffective in reducing anterior cruciate ligament tears, but may be helpful in resisting medial and lateral collateral ligament tears. Functional braces are designed for use by people who have already experienced a knee injury and need support to recover from it. They are also indicated to help people who are suffering from pain associated with arthritis. They are intended to reduce the rotation of the knee and support stability. They reduce the chance of hyperextension and increase the agility and strength of the knee. The majority of these are made of elastic. They are the least expensive of all braces and are easily found in a variety of sizes. Rehabilitation braces are used to limit the movement of the knee in both medial and lateral directions. These braces often have an adjustable range of motion stop potential for limiting flexion and extension following AC. They are primarily used after injury or surgery to immobilize the leg. They are larger in size than other braces due to their function. Soft braces. A soft brace is sometimes also called soft support or a bandage. Bandages, which belong to the field of orthoses, are so-called support bandages, which are supposed to protect the joints from excessive loads. Soft braces are also classified according to regions of the body. In sport, bandages are used to protect bones and joints. One of the purposes of these braces is injury protection. They mostly consist of textiles, some of which have supportive elements. The supporting functions are low compared to paralysis and relief orthoses. Bandages should also achieve proprioceptive effects. Equally, orthoses are sometimes used prophylactically or to optimize performance in sport. At present, the scientific literature does not provide sufficient high-quality research to allow strong conclusions on their effectiveness and cost-effectiveness. Upper limb orthoses. Upper limb or upper extremity orthoses are mechanical or electromechanical devices applied externally to the arm or segments thereof in order to restore or improve function or structural characteristics of the arm. In general, musculoskeletal problems that may be alleviated by the use of upper limb orthoses include those resulting from trauma or disease, arthritis, for example. They may also be beneficial in aiding individuals who have suffered a neurological impairment such as stroke, spinal cord injury, or peripheral neuropathy. Disease is the standard respiratory rate. Types of upper limb orthoses. Upper limb orthoses, clavicular and shoulder orthoses, arm orthoses, functional arm orthoses, elbow orthoses, forearm wrist orthoses, forearm wrist thumb orthoses, forearm wrist hand orthoses, hand orthoses, upper extremity orthoses with special functions, spinal orthoses, scoliosis, a condition describing an abnormal curvature of the spine, may in certain cases be treated with spinal orthoses, such as the Milwaukee brace, the Boston brace, Charleston bending brace, and Providence brace. As this condition develops most commonly in adolescent females who are undergoing their pubertal growth spurt, compliance with wearing these orthoses is hampered by the concern these individuals have about changes in appearance and restriction caused by wearing these orthoses. Spinal orthoses may also be used in the treatment of spinal fractures. A Jewett brace, for instance, may be used to facilitate healing of an anterior wedge fracture involving the T10 to L3 vertebrae. A body jacket may be used to stabilize more involved fractures of the spine. There are several types of orthoses for managing cervical spine pathology. The halo brace is a cervical thoracic orthosis used to immobilize the cervical spine, usually following fracture. The halo brace allows the least cervical motion of all cervical orthoses currently in use. It was first developed by Vernon L. Nicol at Rancho Los Amigos National Rehabilitation Center in 1955. Orthoses for the head. Helmets are an example of orthoses for the head. Orthotist. Orthotists are healthcare professionals who specialize in the provision of orthoses. In the United States, orthotists work by prescription from a licensed healthcare provider. Physical therapists are not legally authorized to prescribe orthoses in the U.S. In the UK, orthotists will often accept open referrals for orthotic assessment without a specific prescription from doctors or other healthcare professionals.